Okay, class, here is, I actually drew this out for you because some of you get visual. So we have to talk about the different anginas. So you've got stable, okay, versus unstable with MI and Prince metals. Okay, so I remember drawing this out on the board. You have to remember, okay, easy is Prince metals, is coronary vasospasms, usually relieved by calcium channel blockers. Okay, you remember calcium influx causes contraction and also causes action potentials. And so the idea is if you got somebody spasming due to vasospastic, material, like, they're, vasospastic chemicals, or in a hypercontractile state due to an influx of calcium, what happens if you block that? The idea, it will decrease some of those spasms. Okay, that's pretty easy. So somebody can have chest pain from vasospasm because while it's spasming, it causes a decrease in coronary artery blood flow. Okay, between stable and unstable. Stable, okay, predictable, pretty much like, around the same time every day. There's a narrowing of the blood vessels. So by the fact that you're having angina, which is also known as chest pain due to decreased, perfusion, and they're having a narrowing of the blood vessels of some sort, you need to have something to cause angina. Okay, but you can think of this as usually a patient that may be having a stable plaque. So like you have some blockage, some narrowing, okay, but it's predictable. It's relieved by rest and by nitro, and usually it lasts, seconds to like few minutes, under like, a 5-10 minutes, but it's relieved by rest and or with nitro. So what happens is nitroglycerin, you do need to know this, is a venous and arterial dilator. So I just want you to think about this theoretically without memorizing it. If you dilate your veins and you dilate your arteries, okay, what you're going to do is you're going to kind of open up your blood vessels, and you're going to do two things. Even though predominantly it dilates, the great thing is it dilates both, so you're going to decrease some of your preload, okay, the load that's being returned back to the heart, and you're probably thinking, well, we don't want to do that, but we're not talking about decreasing, okay, the amount of a ton of volume. What you're doing is you're actually decreasing like the demand, and you're also decreasing preload, the amount of load, so that you could decrease the myocardial workload, and by decreased venous return, and you also dilate the arteries so that you can help with perfusion. Okay, you also decrease the resistance or the afterload that the heart has to work against. And so in this sense, if you remember, you're going to decrease preload and afterload. And that is a good thing, because that means you're going to decrease the overall workload, and you're going to decrease the resistance. And you have to understand preload, afterload, and contractility. Now, you never want to see unstable angina or MI, myocardial infarction, because MI is easy to remember. If you infarct a muscle, that means you've actually deprived the heart muscle of oxygen long enough here to actually cause permanent necrosis or cellular injury. And in that case, you're going to understand that when you actually have MI, remember, go back to what you learned about, aerobic, I didn't spell that right, to anaerobic metabolism, lactate, right, lactic acidosis, okay, and then your cells die, they lyse everything, so what do they leak? Like, potassium, acid, right? That's why you have chest pain, right? That's why you have really weird labs. Now, and then what happens is CK, MB, and troponin. Then you leak that from the cardiac muscle. That's why your cardiac enzymes go up. In an unstable angina, that's usually kind of like the step right before an MI. You never want to see this, because this can progress really fast. Unpredictable pattern, not relieved by rest or nitro, and usually also can progress to an MI, usually greater than 15 minutes, okay? Not relieved by stress or by by rest or by nitroglycerin. That's never a good picture, because then you're talking about somebody who actually may have an unstable plaque, and if it ruptures or it breaks off, it's going to progress pretty fast to a thrombus formation that could end up with somebody in an MI. Thank you.